The 5 women gravida for para 3 comes to labor and delivery ward of a busy hospital in the active stages of labor. A team consisting of nurses, attending physician, and senior resident facilitate delivery of a healthy baby girl. The president begins to repair a vaginal laceration and asks a third-year medical student who's rotating with them on the second day of an OBGYN clerkship to deliver the placenta. The medical student has only observed the delivery of a placenta once before and hesitantly states that he's unsure whether he should perform the procedure independently. The residents say you've seen it done, you should be able to do one by now. The student applies the clamp to the umbilical cord. However, as he gives traction to the cord tears and the patient begins postpartum hemorrhage due to the anatomy inability to deliver the placenta. Interventions addressing which of the following will most likely prevent future occurrences of this type of error.
Okay. Teamwork. Teamwork, a foundation of safe medical care, is safe medical care is undermined. Safe medical care is undermined by hierarchy-based barriers and intimidation. This team leader, senior resident, dismissed concern of the junior team member, medical student, pressuring pressuring the student to perform the task above his skill level, which precipitated an adverse outcome. Behaviors of intimidation can be overt, verbal outbursts, throwing object, passive dismissiveness, impatience. In in setting where leader leaders evaluate and supervise junior learners, intimidation can motivate junior team members to prioritize acquiescence and boldness over caution and patient safety. Suboptimal team dynamics can be improved. Suboptimal team dynamics can be improved through teamwork training, including communication and mentorship and promotion of safety culture, shared prioritization of safety goals. Examples of relevant intervention include teamwork simulation with teams practicing communication skill drills during simulated patient scenarios, safety debriefing consisting of collaborative team-based discussion of patient safety and risk and concern, development of evaluation of metrics rewarding members who identify errors and safety risks. Such intervention can improve communication skills of the team leader, increase psychological safety, comfort in experiencing safety related concern, or asking questions of junior team members and improve leadership responsiveness. Okay.
27 women admitted to the hospital for evaluation of abdominal pain that has intensified over the past 3 months. They describe the pain as severe and has been unable to work due to the symptoms. Medical history includes low back pain, irregular menses, depression, and borderline personality disorder. The admitting senior resident physician obtains a detailed history, after which the patient remarks, "You're a great doctor. I can tell you really understand what I'm going through. Vital signs stable. Physical exam shows mild diffuse abdominal tenderness and is otherwise fine." The next day, the patient is seen by the first year resident physician, uh, who explains her role on the treatment team. She performs a brief physical exam, explains that abdominal CT scan and lab tests have been ordered, and offers to answer any question. The patient refuses to undergo testing and angrily says, "You are not good at your job. I know a good doctor when I see one." You just order tests without even knowing anything about it. Which of the following is the most appropriate response by the resident?
Okay. Patients with personality disorders often display challenging behaviors which can result in problematic interaction with the providers, negative impact care, patients' distrust, and refusal of recommended treatment, demands for special treatment. Patients with borderline personality disorder frequently use the defensive mechanism of splitting, in which they experience the self or others in extremes, either all positive or all negative. This patient polarized views of admitting senior resident as good, "You are a good doctor," and the first year resident as bad, "You are good, you are not good at your job, you are not good at your job," has led to immense had led to an impasse in treatment and potential division within the treatment team. The optimal approach to manage splitting in inpatient setting for all providers to see the patient jointly as a team. This allows the team to present a united front, providing clear and consistent information, preventing miscommunication, and minimizing the potential for splitting to divide the team or interfere with the treatment. Okay.
Next. 45 woman with widely metastatic lung cancer is admitted to the ICU with worsening respiratory distress. The cancer has progressed rapidly despite multiple rounds of second and third line chemo. Her oncologist and primary treating team agreed that her prognosis is poor and that she is not a candidate for clinical trials. When discussing about goals of care when discussions about goals of care are started, the patient and her surrogate decision maker express preferences and sign an advance directive indicating that the treating physician should do everything possible to treat the patient, including cardiac resuscitation and all potential curative treatments. Subsequently, she sustains a large MI with resulting brain injury. Upon learning of the patient diagnosis, the surrogate decision maker asks the physician whether a cardiac catheterization can be performed to treat the MI. Which of the following best describes the physician ethical obligation to comply with the surrogate request?
Okay. A medically futile treatment clears of no benefit. A medically futile treatment clearly of no benefit. Physiologic improvement, reduction in suffering cannot accomplish intended goal. Med- Medical futility can be defined as physiologic futility and qualitative futility. Physiologic futility is treatment cannot improve physiologic condition or reach a physiologic goal, including promoting palliation or comfort. And qualitative futility and and qualitative futility. Treatment offers marginal benefit that are substantially outweighed by the childhood or of significant pain and suffering. In this patient with advanced career who sustained a large MI complicated by anoxic brain injury, cardiac catheterization is unlikely to adequately treat her infarction, alleviate her brain injury, improve outcome, and therefore it's both physiologically and qualitatively futile. Physicians have no ethical obligation to administer futile treatment because doing so encounters the ethical obligation benefiting the patient and non-maleficence not harming the patient. When a patient's surrogate decision maker requests a futile treatment, the physician should attempt to understand the reasons for the request, like distrust, concern for abandonment, overestimating treatment benefit, and empathetically explain why the treatment is futile. In contrast, therapies are at high risk but offer some benefit, prolongation of life via CPR in some patients without terminal diagnosis, not clearly futile. In such cases, physicians should offer clear guidance because cannot refuse treatment if it is requested by informed and competent patient or surrogate. Can you please explain?
Um, so if you determine as a doctor that the treatment is not gonna, it has no advantage on the patient, like it cannot save the patient.
Yes, he has anoxic brain injury,
Yeah,
so like,
the brain is dead.
yes,
So
true.
it doesn't matter even if you do sit you remove the,
CABG.
yeah, the clot, whatever, the brain has already been damaged and the patient has cancer and all that. So if you determine that the treatment is not going to change anything, you don't have to do it. You know, even if the patient says, oh, I told you that in case something happened to me, you have to try everything. If you determine that this is not going to change anything, you don't have to do it. But then you can explain to the patient, I guess, or to the surrogate, because the patient will be probably that why, you can ask them, why do you think like that? Like, why do you want to do that treatment even if it's not needed? And then explain to them that, yeah, even if we do it, it's not going to change anything. The patient is dead. I think that's what they're saying. Does that
Okay.
make sense?
Yes.
Okay. Okay. 10-year-old girl brought to office by mom for evaluation of recent behavioral changes. She's 10 years. The patient has been sleeping poorly and recently started wetting her bed. Grades in school have dropped and she has been anxious and sad. The patient parents are having financial difficulty and considering divorce. The father drinks alcohol most evenings after coming home from work. The mother appears stressed by her husband drinking and is very concerned about her daughter. The physician has known the patient since she was a toddler and found her to be cheerful, lively. Everything was fine 6 months ago. After the mother leaves the room, the physician asks the patient about school and home, at which point she suddenly burst in tears. After providing support, which of the following is the best next step in management of this patient? Mm,
Okay. When working with vulnerable patients, when working with vulnerable patients such as children, it is imperative that physicians be alert to any signs of possible abuse. Abuse may be ruled out in any children with abrupt onset of mood change, or bedwetting or academic difficulties. Other factors associated with increased risk of abuse in the child include unstable family situation, financial difficulties, and caregiver history of substance use. Physician and sexual emotional abuse should be considered early when evaluating mood and behavioral symptoms in children due to high risk of recurrent abuse and the need for prompt intervention. The physician should ask the patient to leave the room, provide a safe environment for the child to talk about feelings and the concerns. If abuse is confirmed or there remains a high index of suspicion, the physician is mandated to report it. Okay,
Okay, you read E.
yes. CBT has been studied for a number of psychological disorders in children or adolescents, although it may have a role in long-term management of this patient. Psychotherapy would be secondary priority and should not delay the urgent need to exclude abuse. Okay.
Next. Research team plans to conduct a multi-center, double-blind, randomized control trial to determine whether maintaining BP control below currently recommended levels has increased benefits in prevention of cardiovascular disease and all-cause mortality. The group develops a research protocol that randomizes patients with a pre-existing diagnosis of hypertension and systolic blood pressure more than 130 to either an intensive treatment intervention group maintaining systolic blood pressure less than 120 or a standard treatment control group maintaining systolic blood pressure less than 140. The researchers plan to track primary endpoints included all-cause mortality, incidence of MI, stroke among two groups for 6 years. Approval for the research is obtained from institutional review board at the researchers' respective institutions, and the trial is started. Which of the following best describes the researchers' ethical obligations regarding oversight of data collected during the trial? Mm, mm,
Okay, option C first.
mhm.
Institutional Review Board, which represent the participating facilities with which the academic trial investigators are affiliated, are responsible for approving the research protocol, ensuring the research conforms to proper scientific and ethical standards, and confirming the presence of informed consent in a data monitoring plan. However, IRB do not perform ongoing statistical analysis of the interim data or assess data integrity. This function should be performed by external committee to prevent bias. So, institutional review board should not do these works
Mm-mm.
like ongoing statistical analysis. They do not collect the data.
I'm going to.
Can you hear me?
No, no. The institutional review board just approves the research at the beginning. It says, okay, you can do this research. That's it.
So
It doesn't.
they do not do like they do not collect the data, or they do not do anything.
No, they just approve. They just give you the okay to do the research. That's it.
Okay.
Mhm.
And like the research product or anything else, they do not have control over on those things also, like the research population and the time thing. Is there any control is present on them? Like, is there any they just give you the permission, like they are just the principal?
Yeah, they just give you the permission. Mm-hmm.
Okay. So randomized control trials, RCT, randomized control trials, pose unique ethical risks. Randomized control trial pose unique ethical risks to participating subjects, because there is significant chance, 50% in a two-arm RCT. Participants will be assigned to an inferior treatment, ineffective or harmful placebo, or experimental intervention. Participants should be advised on their risk during the initial informed consent process. In addition, the study should include ongoing oversight of interim trial data. Data oversight is performed by independent data monitoring committee that comprises a biostatistician and other experts. Committee personnel should be entirely Committee personnel should be entirely external to the research team, and the study sponsor prevent bias and conflict of interest. The research team should submit secured and de-identified data to the committee, which reviews the data in unblinded form to detect and report safety concerns, such as unexpectedly high incidence or severity of adverse event, treatment futility, and issues with data integrity that could compromise study results. Okay, so why
So,
it is the answer?
uh, Yeah, because um the data should be analyzed by somebody that's not the person
Okay.
that's doing the research. By and it was we had a similar question yesterday. It has to be by somebody outside that doesn't have anything to do with the research.
Okay.
Mhm. Does it make sense?
Yes.
Mhm. As the trial progresses, data collected from the participants are regularly submitted to an external committee for ongoing monitoring analysis. The committee confirms that no significant difference in baseline demographics and health attributes between the standard and intensive group exist and finds no excess incident of serious adverse events in the intervention group. Interim outcome data after the first 3 years of trial show the following. Oh, you can see MI is higher in the standard group, and yeah, it's statistically significant. I think, yeah. Death from any cause is higher in the standard group, and it is statistically significant. Stroke is higher in the standard group, but it's not statistically significant. Heart failure is higher on the standard group, but it's not statistically significant. According to research protocol approved by the institutional whatever review board, the trial is scheduled to continue for the duration of 6 years. Which of the following recommendation is most appropriate in this time?
Like in the stroke and heart failure, the data is like p-value is not significant, isn't it?
Mm-hmm.
P-value is like the myocardial infarction and death from any cause, p-value is significant.
Mm-hmm.
Consider stroke. Why it is the answer?
Mm, you you can clearly see that the people are dying from not receiving the intervention. There are people, a lot of people that are getting MIs and dying. So why would you continue?
Like standard, the 519 patient is dying due to standard treatment.
Mm-hmm.
Mm,
Does
So
it
in
make?
like in p-value looks it is significant, isn't it?
Mm-hmm.
So it does not make any sense.
What the? I don't understand. What do you mean?
Like if p-value is significant
Uh-huh.
and the study is good, isn't it?
Like, okay, here the MI, for example, it shows that a lot of people that have the standard treatment, so blood pressure is higher, get MI. The people that have blood pressure less than it was what 120 don't get MI, right? And the
Yes.
p-value is statistically significant. That means that this is true. That what we are observing here is true,
Okay.
right? The same
Yes.
thing, yeah. Same thing here. P-value is statistically significant. That means that what we are observing here is true.
Yes.
People are, yeah. Here, p-value is not statistically significant. That means that this may be due by chance. It's not. It may be true or it may not be true.
Yes. It makes sense.
Yeah, right. Okay. So here, then, since we are saying that a lot of people are dying
Standard
um,
treatment.
from the standard treatment, and we know that this is true because the p-value is statistically significant, then we need to stop the research, because obviously the intensive treatment is working, is more beneficial for the patient.
Okay.
Makes sense.
Yeah, kind of.
Kind of.
Yes.
Can you repeat it?
No, no, I am reading the explanation.
Okay.
If I don't understand, I will ask you again.
Okay, perfect.
These things actually goes over my mind.
Yeah.
Okay, in randomized control trial, in RCT, the randomized control trial interim data are regularly reviewed by external monitoring committee to ensure external monitoring committee to ensure human subject safety and data integrity. The committee may be recommend stopping an RCT early when interim data suggests that continuation of trial exposes participants to unnecessary risk, as in the following circumstances: evidence of benefit, data reveal highly significant differences, p-value 0.005, much p-value 0 much stricter than would be appropriate for reporting study and data, is clinically important endpoints favoring the experimental intervention and mm, intensive blood pressure treatment versus control standard treatment incidence of without excess incidence of serious adverse effect. Evidence of harm, data reveal significantly worse outcome or excess incidence of adverse events associated with the intervention, and evidence of futility, data reveal that the study hypothesis is uh, not provable for statistical reasons, excessive dropout rate, insufficient recruitment. Data from these RCT reveals large population with the incidence of two clinically important points: myocardial infarction and all-cause mortality between intervention group N 323 and 212 respectively, and the standard group 519 and 402 respectively, without the evidence of baseline difference health attributes between groups and serious adverse effects. Moreover, the differences are highly statistically significant. These findings support the study hypothesis that intensive blood pressure control rather than chance causes improvement in MI incidence and mortality.
Okay. Makes sense.
Yes,
58 men with a history of chronic renal failure and schizophrenia comes to the ED with chest pain. A 12 lead ECG shows ST elevation in lead 2 3 AVF. The patient troponin CKMB are elevated, cardiology consult is called, and the patient is prepared for emergency PCI. The risk and benefits of the procedure, including the risk of contrast-induced renal failure, are explained to the patient. He shows an understanding of this condition, the benefits of PCI, and the risk of not performing the procedure. However, despite continued persuasion, he refuses any procedure that might lead to renal failure. On mental status exam, the patient is alert and oriented. His mood is anxious and his affect is flat. He says that he prefers to live alone because you can't trust people not to steal your things. The patient appears, the patient hears voices calling his name daily. Oh Lord. He has no suicidal ideation. Which of the following is the most appropriate next step? Management of this patient.
Okay. Patient who demonstrate a decision-making capacity. Patient who demonstrate decision-making capacity have the right to refuse intervention, including life-saving treatment. Although this patient has diagnosis of schizophrenia, he is alert and oriented, able to communicate a choice and demonstrate understanding of his condition and the proposed treatment, and and ability to reason through the risks and the benefits of treatment and lack of it. His flat affect general suspicions and hearing non-threatening voice on mental status examination are consistent with mild severity of the schizophrenic illness and are not impairing his ability to weigh his specific decisions. Having a psychiatric diagnosis in and of itself should not be determining factor in capacity assessment. Patient with history of psychiatric illness should be carefully assessed to determine if acute symptoms are directly impairing their ability to person. Patient and patient who have severe delusions relationship to medical condition, disorganization, or cognitive impairment. Okay, cognitive impairment may lack of capacity to require a surrogate decision maker. Okay.
Okay. Resident physician in a completing no. A resident physician is completing a pediatric ICU rotation at a busy academic medical center. The resident is highly engaged in the care of patients, frequently visiting them at the bedside, communicating with nurses, and guiding families through difficult treatment decisions. The ICU is frequently busy. Several patients under the resident care experience prolonged illness despite complex interventions, with some dying unexpectedly. Several weeks into the rotation, the attending physician noticed that the resident appears withdrawn during the rounds, often forgetting or being unfamiliar with details of patient histories. Um, the attending physician meets with the resident privately to discuss this concern. The resident becomes tearful and states, "It's exhausting to see so many patients suffering and dying. Even when I'm home, I stay up at night thinking about the patients and whether I'm failing at my job. Maybe I'll be better off withdrawing from this program." The resident is offered appropriate support resources. In addition, which of the following system based interventions is recommended to reduce the future risk of this occurrence in resident physicians?
Okay, holding rounds every 2 weeks dedicated to discussing psychosocial aspect of caring critical illness. Okay, this resident who has prolonged exposure to dying patient has evidence of burnout characterized by emotional exhaustion, insomnia, tearfulness, depersonalization, appearing withdrawn, and low sense of personal accomplishment, at the job, burnout commonly affect physicians in the ICU who have frequent exposure to death and severe illness, but often receive little support for grief associated with caring for dying patients. Residents are vulnerable for perceiving ultimately death as a personal failure and have few protected opportunities to discuss emotionally distressing episodes. Interdisciplinary debriefing sessions, grief rounds, which are dedicated to discussing psychosocial aspects of patient care from the provider's perspective, are associated with improved physician well-being and coping skills. Grief rounds are conducted in specific settings, ICU, with the protected time given to the resident attend regularly, bi-weekly, monthly. They are characterized by the following: team-based structure, physician, psychotherapist, chaplain, interactive format which elicits open sharing of experiences and which elicits open sharing of the experience and reduces perceived stigma associated with expressing emotional distress, and focus on caregiver experience associated with loss and caring for ill patients. Okay.
Okay. Next. Hospital administration leaders at an academic medical center um, formed a committee to review the hospital malpractice claims over the past 3 years. The hospital is in a large city and house staff. Provided teams includes house staff, medical trainees. Several malpractice claims involved serious preventable errors that resulted in death and harm to patients, such as wrong side surgery, medication errors, treatment delays. The committee reported that the frequency of serious adverse events is 25% higher at their institution compared to other academic medical institutions. Which of the following is likely to be the most common root cause of serious adverse event at this institution?
Okay. Medical errors affect 10 to 12% of the hospitalized patient. Errors in complex and high hazard systems such as healthcare result from multiple system vulnerabilities rather than isolated individual actions. Root cause analysis is a retrospective analysis tool that identifies all cause of an adverse event, including active errors, proximal incorrect actions of frontline personnel, and latent errors, distal system level failures. This academic center has a high frequency of sentinel events, which are serious medical errors causing patient's death, severe temporary harm, or permanent harm, according to the joint committee. And the most common root cause of sentinel events involve failures in the communication and teamwork. Examples of such failure is miscommunication, miscommunication during transfer cares, unclear sign out causing patient injury, incorrect medication administration, excessive team hierarchy, excessive team hierarchy causing a fear of speaking up during the time procedure and rounds, and missed opportunities to prevent error, wrong side surgery, poor interpersonal collaboration, or poor interpersonal collaboration involving multiple professions in teams, causing suboptimal patient oversight, failure to detect a serious drug interaction. Factors related to the patient's atypical presentation complexity and providers fatigue from high patient volume, house staff inexperience can increase the risk of human error. However, communication and teamwork are more commonly implicated in serious patient safety breakdown and sentinel events. Safety promoting healthcare system can anticipate and prevent human error in high risk situation through redundancy double checks, sufficient staffing to prevent provider overwork, and effective teamwork to relieve fatigued or inexperienced provider during high stake tasks. Okay.
Okay. Following a prolonged investigation, the committee determined that most of the serious medical errors were directly linked to communication failure among providers. Which of the following is most likely to help the hospital improve patient safety during transfer of care?
Okay, sign out. The process of handing of a patient during transfer of care is a high risk prone to communication failure, omitted or overlooked information, offering medical error, delayed diagnosis, medication error. Standardized sign out templates represent the most effective intervention to improve sign out safety. Following a template ensures consistent and reliable communication of critical information, lab results, medication list, patient allergies. During sign out, physicians should cover each template category systematically, following a checklist to prevent inadvertent omission of important information. Essential aspects of effective sign-out template or checklist include verbal and written exchange of information, including clear, updated written sign-out, pertinent patient information, including do not resuscitate, do not intubate status, clinical status and course and recent events, and clear and anticipatory instruction if the patient's mental status, check ABG, and consider transfer back to the ICU. Can you please explain?
Um, um, they're saying that it's better to use a you know how when there is a shift change and you have to hand your patient to the person that's coming to replace you, right?
Yes.
Here they have like those, yeah, here they have like those templates, where, because you have to give the information of the patient to the person that's going to replace you. You have to tell them, okay, I have this 25-year-old patient that came in yesterday for sepsis, and we
So
gave this.
we don't need the face-to-face communication during
uh,
sign-out.
you, you need it, but they're saying that um, what is more effective is to have a template. You also need the face to, if you can do it, you also need the face to face, and you also need the quiet environment. But what is more effective, so there are no errors, is to have a template to tell
Like
them, okay.
writing everything about the patient, liking important information.
Mm, yeah, but the template already comes with like, like it already comes with like things that are pre-made. So you don't make a new template every time for every. It's just like the template will come with name of the patient, medicines he's taking, and you're just filling that. You're just filling that. So when you hand it to the person that's going to replace you, the person already knows that template, so they already know, okay, in that template I'm going to have the name, the medicine that he's taking, if he don't want to not resuscitate, whatever. So it's already something that's already made, like a checklist that's already made, and you're just filling it up. Does it make sense?
So using a uniform template when conduct. So if template is already made, then what
Uh-huh.
will I do?
No, the template is already made. Like the template says name of patient, but you have to put the name of the patient. The template says medicine the patient is taking. You have to put the medicine the patient is taking. You see, so the template just gives you the categories, but you have to put the information in it. But it's the same template with the same categories for everybody, for all the patients. Did it make sense?
Yes.
Oh, okay. Okay, good.
You want to show something like regarding
I
temp.
wanted to find a template of that hand of templates in ICU, maybe. I don't know. Um, don't know if that one makes it, but maybe this one. Just to show you how does one of them look like. Uh, I guess that would be one, but it's not that complicated. But yeah, that would be one. You see, it's like it already has
Like
like
every
different.
time I am
Uh
signing out, I need
huh.
to fulfill these things.
For for the patients that you are under you,
Okay.
because you are giving, because you are signing up, but the patient still has to be taken care by somebody.
Yes.
So you have to give that. That person never seen that patient. It's you just you're just giving him your patient. So you have to give them all the information, or they're gonna make a mistake on your patient, kind of thing.
Okay.
Yeah. Um, okay. Can you read A and B?
Yes.
Mhm.
Conducting sign out face to face is a conducting sign out face to face in quiet environment is recommended. However, sign out templates are more effective in improving patient safety as they directly increase the reliability of critical patient related communication. Moreover, face to face communication and maintaining quiet environment are not always feasible. such as in transitions of care from a busy emergency department to an inpatient unit in a different building. Although physicians and providers should be educated on sign-out best practices, individuals may deviate from di- didactic 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 instruction in setting of complexity and fatigue. Using a uniform template in real time is more likely to ensure consistency of sign out and promote patient safety. Okay.
Next. A double-blinded randomized controlled trial, double-blinded, is being conducted to assess whether a new chemo agent can prolong survival in patients with stage 3 lung cancer. Recent research studies using a small group of subjects reported that the agent demonstrated the ability to reduce tumor burden. Investigators conducting the current trial now plan to randomly assign a larger number of participants to receive the experimental treatment or a control intervention and measure differences in survival between two groups. Which of the following characteristics should be present within the research trial to ensure adequate protection of participants' welfare?
Okay. Our randomized control trial are graded the most statistically unbiased method for determining whether an individual new chemotherapeutic agent causes an outcome and increased survival. Randomized control trial pose ethical risk because patients lack autonomy in choosing their treatment and are randomly allocated to an intervention that may, dependent on study results, be found to be inferior. Control and experimental arm randomization of randomization of the patients within the RCT is ethically permissible only if there is general uncertainty, clinical equipoise, and regarding the effectiveness on the experimental compared to the control intervention. Eh, is unnecessary. Equipoise is necessary to study design and ensure that the trials does not knowingly randomize participants at the outset to a clearly inferior or superior arm. For this reason, randomized control trial typically test interventions that are hypothesized to have benefit based on lower quality evidence. Small pilot today, but lack robust evidence or widespread scientific consensus for their effectiveness. Determining effectiveness that represents the primary purpose of our safety. Okay,
Okay.
can we stop here?
Yes, we can.
Okay,
Okay. I'll see you tomorrow.
okay, bye bye.